Good morning, everyone. It was just to say that there'll be some information put in the chat for you, and we'll kick off roughly at about 2 minutes past, just when everybody's been let in. Good morning. I think we'll all just make a start. So my name's Lindsay Young. I coordinate the SASW MHO Community of Practice, and I'm the current co-vice chair of the National MHO Forum. I'll be the chair for today, and it's my pleasure to welcome you all to the SASW MHO Conference 2024, Embracing the Unknown and Finding Hope. I think it's fantastic that we have you all here today at our event, hosted by SASW and supported by the Scottish Government and Social Work Scotland. We've worked hard this year to bring you an eclectic programme, which has been built on the feedback from last year's conference. MHOs have a unique role within social work, and we've been conscious to ensure that today is focused on MHO practice. We feel it's a truly representative programme for MHOs and by MHOs. This morning we will have 5 keynote presentations which will run concurrently, with an opportunity for questions to all of the speakers at the end of the presentation. So that will roughly be around 11:40. You can add your questions into the chat and we can raise these on your behalf, or you can use the raised hand function during our question time to ask speakers your questions directly. You may have noticed that the MHO Practice Award has been taken out of the programme for today. We made this decision based on lack of nominations. We know that there's excellent and innovative MHO practice going on across Scotland at the moment, and the lack of nominations is symptomatic of how busy MHOs are and our competing demands. We'd love to hear your feedback on whether you'd like us to keep the award in for next year's programme. We feel it's a great way to hear about and praise the good work of MHOs and MHO initiatives, but we also recognise that you may feel it's not needed. It'd be great to get your views on this in the chat, or please feel free to send your feedback in to scotland@baswa.co.uk. The hashtag for today's conference is in your programme. It's MHOConf24, so please feel free to tweet throughout the event. So now to business. This afternoon we have 6 workshops, and I'd just like to reiterate just now that all of the workshops will be running, as I know there have been some communications that workshop C wasn't going to go ahead. Each one will be running twice with a 10-minute break in between, so you'll have an opportunity to attend 2 workshops this afternoon. The links to each of the workshops you've pre-selected have been sent to you. We'll also list these in the chat so that you can save them for after the lunch break. The themes for this year's workshops include MHOs and adult support and protection, working with corals in the community, the legislative complexities of ARBD, community CTOs in practice, complex cases with the Mental Welfare Commission, and child and adolescent mental health. We also have a wonderful speaker lineup for you today. with our morning keynote speakers including Professor Neil Quinn, Professor of Social Work and Health Equity at the University of Strathclyde, Iona Colvin, Chief Social Work Advisor at the Scottish Government, Julie Patterson, Chief Executive of the Mental Welfare Commission. From our Highland MHO services, we have Susie Redman, Principal MHO, Ewan Williamson, Interim Principal MHO and Forensic Lead, and Vida Rastaboska, MHO, as well as Marie Todd, MSP and Minister for Social Care, Mental Wellbeing and Sport at the Scottish Government. The key themes for today centre around how we can embrace and find hope in the future. With MHO capacity issues, workload pressures and budgetary constraints, it's more important than ever that we work together to protect the profession and build real sustainability for the future. We're also on the cusp of a sweep of legislative change. A changing legislative landscape is daunting, but it also offers us a chance to shape the future of practice and develop systems that promote rights-based practice and citizenship for all. With that in mind, I'm pleased to introduce our first speaker, Neil Quinn, Professor of Social Work and Health Equity at the University of Strathclyde.
Thanks very much, Lindsay, and good morning, everyone. Thank you for the invitation to speak at your conference today. I'm a former mental health officer and a number of years ago, and as a former MHO, I'm delighted to join you today and share some thinking with you on two concepts that I feel are really important for mental health practice, and those are human rights and citizenship. And I think they fit very well with the themes of the main theme of your conference about finding hope, because I think they offer they're very hopeful concepts, and I think offer an important contribution to thinking about how we might develop practice in the future. Before I start my presentation, I'd like first of all to acknowledge the contribution of colleagues who have collaborated with on this work and who've shared ideas with me for this presentation. And they are Dr. Gillian McIntyre and Dr. Ailsa Stewart at the University of Strathclyde, and Professor Michael Rowe at Yale, who is a leading academic on mental health and citizenship. And I'd also like to name check Frank Riley, who's on the call today, and I think was involved in the organisation of the conference, who's been an enthusiastic supporter of the work on citizenship and taking that forward in different frameworks. So next slide, please. So I'd like to do three things in this presentation: to introduce human rights and citizenship as concepts, and I'll first of all look at human rights and then citizenship. Consider what these concepts mean for mental health, because they've originated outside mental health, but I think can be applied to mental health, and particularly, and then thirdly, to discuss implications for practice. Next slide, please. So I'm going to start by looking at human rights. So as you all know, the Universal Declaration of Human Rights was founded after the Second World War in 1948. It involved rights to human dignity, civil and political rights, and then latterly economic, social, and cultural rights. And what the Universal Declaration is an articulation of universal human rights, values and standards. And these rights have been endorsed in a number of other human rights declarations, treaties, and conventions, such as the European Convention on Human Rights. Human rights instruments, I think, are important because they provide the means to meet basic needs and be represented at a political level. They're underpinned by basic principles of non-discrimination, equality, self-determination, and the right to political participation. And they involve critical thinking on governmental responsibility and benchmarks for interventions in all sectors of society. And one of those sectors is social work. Next slide, please. So I would argue there's a very important and strong link between social work values and human rights. I've would argue that human rights is an important underpinning framework for social work practice. They provide social workers with a moral basis for their practice. And we know that social work values and principles are very much consonant with basic human rights. There's a belief that every individual has certain human rights is central to social work practice, I believe. And there's a number of social work writers that have developed this idea, particularly Jim Ive, who's an Australian academic who's talked a lot about this. Individuals have a right to be treated with fairness and respect, to be protected from abuse and exploitation, and to be granted the opportunity of having a family, a basic education, meaningful work, and access to essential health and social services. Next slide, please. And within that human rights framework, I'd now like to move on to discuss one of those human rights frameworks, the UNCRPD, which is highly relevant to your roles as MHOs and has a bearing on mental health legislation in many countries. It was adopted in 2006 and enforced in 2008, and includes those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. And within the UNCRPD, psychosocial disability is used to refer to people with mental health problems. And I guess one of the questions arising out of the UNCRPD is, are issues faced by people with mental health problems the same or different as for other disabilities? That's one question I think it raises. Next slide. If we apply a human rights framework to understand the needs of mental health service users in Scotland, then a key piece of work I think we need to look at is Rights for Life, which is a declaration of rights for mental health in Scotland. This study found that people with mental health problems experience high levels of stigma discrimination, are often poorer on average than those without mental health problems, have fewer life opportunities, can have their rights legally limited as a consequence of mental health problems, are often excluded from decision-making processes, and can be denied access to timely and acceptable quality care. So what this piece of work found was that people with mental health problems experience human rights violations in a number of ways. Next slide, please. And here are some of the ways in which people's rights can be denied. So the right to be treated with dignity and respect, the right to the highest attainable standard of physical and mental health, the right to free, meaningful and active participation in decisions at all levels, the right to hold duty bearers to account, the right to independent advocacy, the right to equal treatment and recognition by the law, and the right to enjoy the full range of economic, social, cultural, civil and political rights. So in many ways, people with mental health problems have their rights denied. And this is a key challenge for us, I think, as mental health practitioners. Next slide, please. And as we know, we work within a context where there are challenges to securing those rights, and that includes limited resources. And I think we heard about that in the introduction. And obviously, that's getting more and more challenging with some of the fiscal pressures that we're seeing at the moment. Another big challenge is around how we ensure effective participation of people with mental health problems, of service users, but also of named persons and advocates within the process. Another challenge is ensuring appropriate support to named persons and carers. We know there are issues with power imbalances in practice, and I know you will encounter these in your practice as MHOs. So the power imbalance, particularly between medical staff and people with mental health problems who are going through this process. There's often a limited awareness of equality, diversity, and CRPD requirements that needs to be addressed. And we need to move beyond a biomedical model to more of a social model of mental health. And obviously we're on a journey in that respect, but I guess there's still work to be done, I think, on that. Next slide, please. So there are a number of recommendations for how we secure people's rights, and here are just some of the ideas around that that have emerged. So think about how we identify and challenge imbalances of power, both within the service system, but also within wider society as well, because we know that often people with mental health problems are powerless within wider society. How do we identify and overcome obstacles to participation and contribution? How do we remove some of those barriers and ensure that people can make a meaningful contribution? How do we ensure access to independent advocacy and legal representation, for example, for named persons? How do we ensure reasonable adjustments to tackle discrimination and promote inclusion? How do we challenge some of those broader social and political inequalities and ensure that people with mental health problems play a full part in society? And that's something I'm going to discuss in the next part of my presentation. How do we ensure that practitioners are trained in a human rights-based approach and skilled in defending people's rights? How do we evaluate mechanisms and try to improve those, including the role of named persons and advanced statements? And how do we always ensure that duty to consider alternatives to compulsory treatment? So that's an introduction to human rights, and I would like to move on to the other concept that I was wanting to explore in this presentation, and that was on citizenship and ideas of citizenship in relation to mental health. The ideas on citizenship have been developed in many ways separately to work on human rights and mental health, but as a concept, I think it offers an important way in which people's human rights can be realized. So this is a picture of refugees at the Mexican-US border who are trying to secure US citizenship. Next slide, please. And this is an image of protesters in Hong Kong trying to protect their identity as Hong Kong citizens within the Chinese state. Both cases, I think, demonstrate that citizenship matters to people in different parts of the world. And I guess closer to home, we've had a huge debate about citizenship in relation to both the Brexit and Scottish independence referendum. So citizenship is a very much a live issue. Next slide, please. And if we think about citizenship more broadly, I think the very practical reasons why citizenship matters. So, for example, we want citizenship because we want a driver's license, or we want a bank account, or we want a passport so that we can travel to other countries. And at more of a basic needs level, citizenship is important because we want adequate housing and we want the opportunity to gain employment. So there are many ways in which citizenship is important. And next slide, please. And in terms of defining citizenship, one definition of citizenship is the position or status of being a citizen of a particular country. And that's important because being a citizen of a particular country helps us to access specific rights. And one of probably the most famous person that's talked about citizenship, T.H. Marshall, argued that citizenship is a status that confers individuals with a specific set of universal rights which are granted to them by the state. And this is important, and many of us would, we often take these rights for granted, but when people are denied those rights, for example, as migrants, then we see a whole set of things which are not denied, which are rights which people can access, and this has relevance to the whole area of mental health, because often we see people with mental health problems being denied basic rights. Next slide, please. So why is citizenship important for mental health? And it's really because of the issues we've identified earlier, which indicate that people with mental health problems are being denied full citizenship through the discrimination they face in a range of areas. So a citizenship approach to mental health starts from the premise that mental health is affected by structural as well as individual factors. So those wider factors. So, for example, people with mental health problems experience more poverty than the general population. And a citizenship approach argues that mental health services must therefore include attention to the service user as a person living in society and in relationship with others. So it's thinking about that broader societal context that people experience. And if you were critiquing mental health services, it could be argued that they've focused primarily on the individual and their deficits rather than strengths and relationship with others and their position within society. Next slide, please. So a citizenship approach to mental health moves beyond the traditional narrow view of the mental health care system, focusing on the management and treatment of symptoms, and involves thinking about those broader social needs, and ultimately involves challenging health and social inequalities and tackling some of that discrimination that I discussed earlier in relation that people with mental health problems experience. And if you take a citizenship approach, it's about ensuring that people with lived experience can be recognised as valued, contributing members of our communities, where some of those barriers can be moved and some of that discrimination that people experience can be addressed. A citizenship-orientated system of care promotes personal recovery, not only at the individual level, but also at the societal level as well. And that means removing some of the barriers that people experience. Particularly in accessing services, but also playing a full part in society. Next slide, please. So I mentioned Professor Michael Rowe at Yale, and he and colleagues have developed this notion of the 5 R's in relation to citizenship. And what that means is that it means citizenship is defined as a person or people's strong connection to the 5 R's of rights, responsibilities, roles, and resources that society offers its members, and relationships, including friends and supportive social networks. And that this involves a sense of belonging that's validated by others. And what colleagues at Yale have done is develop a set of programs that helps these 5 R's to be realized. So there's a range of ways in which a range of programs have been developed which ensure that people's rights are protected, that they are able to play a full role within society, and that they can access resources, particularly financial resources, that enable them to do that. So I don't have time today to talk about all these programs, but there's been some innovative work that's helped to ensure that these 5 R's are realized. Next slide, please. So one of the pieces of work that was done in Yale that we've adapted in Scotland is developing a citizenship measure. Now, this was developed in Yale and identified a range of ways in which people with mental health problems realise their citizenship. But what we didn't want to do was just adapt, as to lift that work and apply it to Scotland. So my colleagues at Strathclyde, Dr. Gillian McIntyre and Dr. Elsa Stewart, developed a piece of work looking at how we develop a citizenship model that's relevant for Scotland. And there was a whole rigorous process that went through of doing that in terms of developing a measure. And crucially, it involved peer researchers at all stages of the project. So a number of peer researchers were recruited to be involved in undertaking the project and developing the measure in collaboration with academic colleagues, and a number of third sector and public policy colleagues were involved as well in this process. Next slide, please. So what happened through that work is that a number of key themes were identified of what citizenship means to people with mental health problems in Scotland, and these were the 5 themes that emerged. So first of all, building relationships, that ability to be socially connected with others and to be part of our community and wider society. Principles of acceptance and autonomy, so how to be accepted by families, by communities, by society more broadly, and have that independence and autonomy to realise one's rights. It means having access to services and supports, and the appropriate services and supports, and to have barriers to service access be removed. It means having shared values, both with other people with mental health problems, but within wider society as well, and having valued social roles within communities and within wider society. And then finally, the last theme to emerge was people having civic rights and responsibilities. So having a clear sense of what the rights were, and to see what their responsibilities and role within society was. So it was a really valuable piece of work. So just to sum up in terms of citizenship, what citizenship is about in mental health is reorientating mental health care from the individual to the collective. It's about moving the focus from the mental health system of care to looking at how we promote inclusion of people with mental health problems within society. It's also about addressing power imbalances and transferring power from the service provider to the person with lived experience, so that people with lived experience of mental health problems feel empowered. And it's also about ensuring the participation of people with lived experience in policy making, because I think if power imbalances are going to be addressed, then we have to look at how we involve people in policy making. There's obviously some good examples of that in Scotland, particularly with the last mental health legislation, and also with current legal reform. Again, we're looking at how we ensure participation. Next slide, please. It's my last slide. So just to conclude, I think that human rights and citizenship offer are important guiding principles for mental health practice. I think they offer a lot for the future, and particularly in terms of building hope. They focus on tackling inequalities and addressing power imbalances. They emphasize relationship-based practice. And finally, they involve the full and equal participation of people with lived experience of mental health problems, both in practice and policy, but also within wider society too. Thank you very much.
Thanks, Neil. Next, I'd like to welcome Julie Patterson, Chief Executive of the Mental Welfare Commission.
Thank you very much. And thank you so much for the invitation today. I really welcome the invitation to come to this annual MHO conference again, both as a Chief Executive Officer of the Mental Welfare Commission, but also as a mental health officer. So I'm delighted to be here. So thank you. Next slide, please. I think just for any new mental health officer that's in attendance today, just really keen to reflect on the role of the Mental Welfare Commission and the fact that we are an independent organisation. We're often described as a watchdog, and we're really quite proud of that independence and value it. Next slide, please. And we protect and promote the rights of those people with a mental illness, learning disability, personality disorder, dementia and related conditions. We are particularly concerned for those people on the mental health continuum who are experiencing severe and enduring mental illness, mental health conditions, who are at risk of detention or have been detained. And we're really keen for those people, for those voices not to be lost in the midst of the whole population mental health and well-being. Obviously, it's really important for everybody's mental health and well-being, but this is a really small and significant group that we need to make sure that those voices are heard. And these are the same people that you as mental health officers work with. So we work in partnership together with you to make sure those voices are heard. Next slide, please. And I think it really leads me to the invaluable role of the professional mental health officer. I think it's really important that, as you know, within the Mental Welfare Commission, we have a number of social work officers, all of whom are highly experienced mental health officers and mental health managers. I myself, as a mental health officer, that training has served me well throughout my career. It's just really, really important. And I think it's important to just take time to reflect on why the professional mental health officer role is so important. First of all, as an experienced social worker, Scotland's MHOs differ from England. So we have the approved mental health professionals in England, where we have social workers, we have occupational therapists, nurses, psychologists, fulfilling that role. Scotland is very different. Scotland, the mental health officer role, as you know, is based on a social worker, a really experienced social worker role. And that social worker role is really important. And lots of what Neil just said previously, really resonates with all of us as social workers. The social worker is trained to take that holistic view, to work in partnership with a person, to empower that person and understand the multifaceted life of that person in terms of what's important to them. And the social worker is about not creating dependence, but promoting independence, listening to that person. And actually, sometimes a good outcome in a social work relationship with a person is no longer needing a social worker because that person's been empowered to make decisions for themselves. And linked to that, given the strength of that social work role, an MHO as an experienced social worker has that additional specialist training that is so important in mental health and therefore fulfills that unique role of a mental health officer in Scotland. So an autonomous decision maker, bringing a wealth of training and experience as a social worker, as a mental health professional, and a sound value base to work in partnership with people. So recognising the person, as an individual, not as a patient or a service user, which can be quite disempowering, but as an individual. So the mental health officer role, let's never underestimate how valuable that role is and how critical it is too. Next slide, please. And I'm going to caveat with set a caveat for everything going forward, because I am going to talk about some learning that we've identified at the Mental Welfare Commission. But the caveat is that there's some excellent work that we know goes on in relation to mental health officers, in relation to supporting and protecting the rights of individual people. There's excellent work going on. But the caveat is that we know that, but I'm going to talk a wee bit more about some of the learning that we found, and just really highlighting learning that you and we all need to learn from to continue to protect and promote the rights of the people that we are duty bound to serve. And they are some of the most vulnerable adults and children in our society. So I will talk about learning, but that's not at the expense of there's wonderful work going on, and we know that. But what we are finding is, as a safeguard, it's really important, the MHO consent continues to go down. The rate of EDCs with MHO consent continues to go down. The rate of social circumstances reports, the numbers of them being completed, continues to go down. And when we look at cases at the Mental Welfare Commission, we sometimes find that there's no designated MHO, and the reviews happen, but the designated MHO or the MHO maybe meets the person for the very first time. So in our view, we're becoming passive recipients of information rather than active participants in a person's care. And that's not what we want from the MHO, who are able to form independent views if they have the time and the capacity to actually build good relationships with people. Next slide, please. So you'll see, in terms of the MHO consent for EDCs, we have reached the lowest ever last year with 36.6%. It's such an important safeguard at the EDC level, but the MHO consent isn't happening. However, we do know that's multifactorial. Sometimes there's quick to say there's not enough MHOs, and there isn't. We know that the challenges are significant. But in terms of this particular area of work, it's not all about not having enough MHOs, because we know that there's training identified for junior doctors who don't necessarily contact MHOs. We also know that GPs require training or don't always remember to phone the MHO. And we also know that there's sometimes issues with out of hours, there's sometimes issues with telephone lines and contacts. And we also know there's emergency situations which we know there's no time to get an MHO. So it's multifactorial, but we do need to drive these rates up where possible. And in terms of Mental Welfare Commission, you may know, you maybe don't know, that we meet every year at the end of the calendar year with senior members of staff across all health and social care partnerships, so chief officers and various senior managers, and we discuss some of this information. We're really keen to make sure the safeguard of the MHO grows and is in the right place to support the people that we are duty bound to protect. So we really welcome the information we've been given about the improvements that are being made, the increase in training for mental health officers. However, at some of these meetings, we've also been told that our figures are not comparing like for like. What we've been told is that in some occasions that the EDC consents are being done over the phone in some areas. So some areas are looking at whether or not we should add, I've just seen a wee comment coming up there, which is really good. Some areas have said to us, in order to make sure that MHOs are given consent, just like the person who just commented there, we should be looking at the form and changing that form to make sure that the signature of the MHO is added to it. Now, we're not familiar with the fact that EDCs consent are routinely being given over the phone, so we'll be really keen to hear from you if that is the case. But there is that suggestion that if it is the case, which we would agree with, that the MHO consent should be on the form and should be signed by the MHO. We've also been told that despite real efforts to train staff, that MHOs don't necessarily stay. And again, we've heard that there's a growth in agency MHOs from some areas, and I'd be really keen to hear from you as well about, is that an issue going forward, and the fact that we don't have that continuity of MHOs going forward, and when we do train MHOs, we can't keep them. Next slide, please. I'm going to go on and talk about a wee bit about Mr. E, which you may or may not have had a chance to read. This is our investigation report, which was published on the 25th of January 2024. Next slide, please. In this slide, I tell you a wee bit about who is Mr. E. I tell you that because Mr. E told us that he felt ignored. And I think with our social work and our mental health officer value base, that's really hard to hear, that somebody said that felt ignored by the professions that are duty bound to support that person. No one took the time to get to know Mr. E as a person. No one knew that Mr. E loved his mum's cooking. No one knew that Mr. E enjoyed music or enjoyed visiting charity shops. No one got to know his mum. No one spoke to his mum either. And we were told that mum didn't speak English, but she did. We were told that mum was hard of hearing, but she wasn't. Mr. E was detained on 4 occasions, and there was never an SCR done for Mr. E. What difference an SCR would have made to Mr. E's life had that been done? And we were told in this area that SCRs were only completed if the RMO asked for one. That's not the autonomous decision maker that we're aware of as an MHO, and just really keen for you to reflect on that. Is that practice in your area? We're also told that where there's concern about somebody's mental health and well-being in the community, that the MHO wasn't able to ask and consult psychiatrists to jointly assess in the community. It was only the other way around, that the psychiatrist would ask the MHO, but the MHO didn't have authority to ask the other way around. And again, is that your experience? We would hope not. And in Mr. E's case, when the team did decide that a short-term detention was necessary, it took 11 weeks to then progress that short-term detention certificate. And when we spoke to individuals in relation to this, the MHO service thought the delay was because of the lack of RMOs, and the RMOs thought the delay was a lack of MHOs. Nobody actually knew why there's an 11-week delay. Next slide, please. So Mr. E was in effect living in poverty in a single room for 5 years, but the local authority had £24,000 of his money because they were corporate appointees. And it links to Neil's presentation previously. The 5 hours that Neil mentioned weren't realised for Mr. E. And we found there was a real lack of understanding of the 3 key pieces of legislation that we all work with in order to protect and support the people that we work with. So AWI, Mental Health Act, Adult Employment Protection Act, it was really quite confusing for people, especially when there's looking at the interrelationship between the various aspects of the law. it was very much taken in isolation and not looking at the crossover of the legislation. So we found that we learned that MHOs historically, when maybe they had capacity or there's more MHOs, they were very supportive in training other people in relation to the crossover of the acts and helping people understand that. But with the fact that we've got so few MHOs and the capacity is so stretched, that training or that expertise is not able to be shared, and other staff are struggling to understand that too. Next slide, please. And Mr. E is now blind and has poor mobility such that he has to use a Zimmer, and he now has partially treatment-resistant schizophrenia because he didn't receive his treatment for so many years. And he's in his 50s, and he asks that we all learn from his story. And I think, as I've said before, I think we're all duty-bound to learn from that about when things don't work well, the impact it has on the individuals that we work with. Next slide, please. And just in terms of reflecting on learning that the Commission is finding, I'm just going to reflect a wee bit on our community-based compulsory treatment orders being the visits that we undertook. And thank you to the 115 MHOs who supported us on this piece of work. And you might have seen the report. It was only published yesterday, and it was actually Yvonne Bennett, who's in one of your workshops this afternoon. She was on the radio this morning talking about this, so speak to Yvonne later on this afternoon. But you'll see that there's been a 44% increase in the last decade of community compulsory treatment orders. For those of us that have been around prior to this current legislation, and we all worked in the previous Act, we didn't have CCTOs in the previous Act. There's been a 44% increase in this last decade. In terms of dynamic review, we found it difficult to know how people got off a CCTO. It seemed that once you were on an order, it was really quite hard to get off it. And trying to figure out who was involved in that review, who the contacts were. The main contact was the community psychiatric nurse, not the MHO and not the RMO. Next slide, please. Next slide, please. We'll be struggling with the next slide. The next slide simply tells you that we've got 1,356 people on CCTOs currently, a significant number of people who are subject to what is in effect potentially coercion in the community. I'm assuming we have problems with the slides, or can other people? Oh, there we go. That's great. And this slide talks about a community CTOs. What we found is there's 508 people. So 508 people who have been on these orders, CCTOs, for longer than 2 years or more, without any recall and without any issues in relation to their circumstances. There's relative stability in terms of these people's orders and their lives. More men than women in relation to these orders. And you'll see that some people would have been on the orders for up to 17 years on the CCTOs. And we plan at the Commission to look into the circumstances in more detail, because we're trying to understand why people have been on these orders for so long. And we will look at the 41 people subject to the orders for 10 years or more. But I would ask you to, maybe you already have signed up for Kathleen and Yvonne's workshop this afternoon, where they will talk about this report in more detail that I say was just published yesterday. But it raises lots of questions for us about CCTOs. Other countries have suggested abolishing CCTOs. We don't recommend that. However, we do recommend that there's further research needed, and that's in keeping with what Scottish Mental Health Law Review has said as well. Next slide, please. An authority to discharge report. A survey showed that 85% of MHOs are aware of authority to discharge report and unlawful moves that were highlighted in that report. And we really welcome the fact that MHOs are aware of this report. And we also welcome the attendance by MHOs and a whole range of professionals to the AWI training that flowed from this piece of work that Joe Savage leads on for the Mental Welfare Commission alongside Nez. We welcome this. We have great confidence in MHOs that when there's learning identified, whether it's from CCTO, authority to discharge, Mr. E, or any of our other work, that MHOs will learn from that and they'll address them and challenge where necessary as well. Authority to discharge was a good example of that. And whilst today I raise examples of learning because of Mr. E, because of the CC2 visits we've undertaken, we know there's a great deal of good practice going on too, and we will never underestimate that. And I refer to my caveat at the beginning, we do know where there's good practice. Today I am focusing on the learning, that because I know today's a really good opportunity to get as many MHOs together to share that learning, to decide whether it's happening in your area or not, and if it is, to address that and challenge that. Next slide, please. So I started stating that in one of my slides earlier that MHOs are ambitious for the people we serve. We as MHOs, we look forward to improved outcomes for people. We look forward to recovery. And the Scottish Mental Health Law Review is also ambitious for the people that we serve. We very much look forward to the delivery plan that the Scottish Government will be publishing, hopefully in the next wee while. We've certainly been told it'll be early 2024, so that delivery plan will be important for all MHOs and all of us going forward, because the Mental Health Law Review, it's 3 years of evidence, which I'm sure you contributed to, and it recognised that our laws are 20 years old. In saying that, our laws 20 years ago were very much of their time. However, 20 years on, the people we work with deserve laws of their time now. Next slide, please. And next is all about ensuring that the key role of the mental health officer as a trained social worker delivers that reform in partnership with others. That is so important. Let's not underestimate, as I say, the power of the MHO, to challenge, to have those autonomous decisions, to, as Neil said earlier, to really balance that medical model so that we have a real focus on the person and the individual. And I know Iona is going to talk next about the work that's been done by the Chief Advisor's Office to support and protect the workforce. And I and you will be really keen to hear about that. And as it was said at the beginning, it's really important to protect the profession of the mental health officer because of the invaluable work it does. And we need to continue with that and look forward to working in partnership with you as we continue to do that as law reform does progress. And let's make sure it does, so that we can do our jobs and protect the most vulnerable adults in our society. So thank you very much. Thank you.
Thank you so much, Julie. I can see from the chat that there's a shared concern around EDCs, and it'd be good to explore this, I think, a little bit more in the questions section. I'd like to welcome Iona Colvin, Chief Social Work Advisor to the Scottish Government next.
Thanks very much, Lindsay. And thanks, Julie. That was really interesting. And you posed some really difficult questions there. I will do my best to answer. Can I have the next slide? Thanks. So I'm Iona Colvin. I'm the Chief Social Work Advisor for the Scottish Government and lead a team within government working around social work specifically. Today I'm going to talk a bit about the work that's been done so far and then try and look forward to where we want to be, because I think it's very clear from what Julie's just told us that we're not in a position that we really want to be in. So I want to talk about some of what we've done, some of what we need to do, colleagues, and I'm really fascinated by the chat. It's really interesting, so I'm going to try and keep an eye on that as we go as well. So you'll see from this slide that there's been a slight increase in the number of mental health officers in 2022, and I'm sorry, but that's the last figures that we have, and a slight increase in the numbers of people working as MHOs. And it's the highest since 2016 in terms of the numbers of hours spent doing MHO work, MHO duties. But I think it's very clear that it's not keeping up with demand. And that's a fundamental issue for us, and the issues that you are putting in the chat here in terms of your position in the whole system and what happens in reality on a day-to-day basis. Next slide, thanks. So we've put some money in. It's not a huge amount of money. We've put in money around training. We've put in money around additional MHO capacity, in total 12.13 million. Sadly, that resulted in an extra four extra mental health officers, and yes, I did say 4. And I think basically we need to understand more about that. I suspect that what's happened is there's a higher, that in fact we would have reduced the number of MHOs if we hadn't funded anything in the training, because there's been quite a high attrition rate of MHOs, and that's because of the age profile of the MHO workforce, I think. But the thing is, I don't know that for definite. And that's one of the issues that we have, colleagues, is we don't have a clear enough picture of the workforce. And when you combine that with the rising demand, then it's clear to see that we have a difficulty. So it would be good to understand that. It'd be good to hear what you think in terms of why that only ended up with an extra 4 MHOs across the system. But it's something I think we need to look at in more detail. And I know that COSLA have been looking at that with colleagues in the MHO forum. Next slide, thanks. So a number of other actions going on as well. Looking at, we have an MHO workforce capacity oversight group. Clearly, we need to get more into the detail, I think. We're working with COSLA and Social Work Scotland and SASW to agree a joint improvement plan for social work. So we're not saying that everything we've got just now is acceptable, because we know it's not. And we are looking to see what we can do in the short term in terms of increasing particularly MHO capacity, but not only MHOs. The crisis is much wider, and I'll talk about that in a moment. And we're working with the remote and rural areas to look at what needs to happen. And I saw a number of comments in there about the challenge of being an MHO in a remote and rural area. So I think we need to think a bit more outside of the box and what we can actually do in remote and rural areas. And we have committed to working with the COHI around that issue. And of course, our National MHO Forum, hosted by SASW, continues to share good practice across the piece. So next slide, thanks. But it's not enough, really. So this is the state of the workforce just now. We've Social Work Scotland and SG and SASW have done a number of surveys across the workforce recently, looking at what's happening. And thanks to all of you who responded to those surveys, but it's very clear that we have a number of issues. As I said earlier, there's very little in the way of workforce planning going on. We are, during the pandemic, we saw a decrease in demand, but since the end of the pandemic, we are seeing a slow but steady increase in demand. It's not just the demand, but it's also the complexity of the demand is coming through in a lot of what particularly the Chief Social Work Officers are telling us in their reports. And we know from feedback from everybody that the landscape, the policy landscape and the legislation landscape is becoming more and more complex, and that is becoming increasingly difficult to respond to. There are recruitment challenges in almost every single local authority now, even Glasgow, who traditionally are the ones who fare the best, but some areas, for example, 49% vacancies in their children and families teams. We're seeing a move of children and family staff over to adult services. There's a number of issues that we need to get underneath the skin of, really, and we are seeing poor retention of new social workers, with many social workers, I think about a quarter of social workers now leaving within 6 years of having qualified. And we have significant issues with our student social workers, both in terms of how they're funded to train, and also how they get access to local government, particularly local authority statutory placements. And I think that's really important when we think about the MHOs of the future. We need to get them the ability to be able to experience that statutory work and to gain that interest in mental health work, which is fascinating. And I think it's really important that our student social workers get that opportunity. So we have basically, colleagues, got a crisis right across the workforce now. It is perhaps at times most acute in mental health officer workforce, but you are not alone in that. And I know that won't make you feel any better. It certainly doesn't make me feel any better about the situation we face. Next slide, thanks. So, colleagues, basically what I'm saying is we've done some things, we've not done enough. And I think we've been working with our colleagues in COSLA and Social Work Scotland and SASW and Unison to look at how we can develop a national social work agency as part of the proposed new National Care Service. And Ms Todd will talk later, but you'll know that the National Care Service Bill will be debated tomorrow in Parliament. This is a partnership. It's not a Scottish Government only thing, it's a partnership. It's about a partnership between Social Work Scotland and Scottish Government in terms of moving forward around the staffing of this, but it's also a partnership with SASW, and it's about bringing all the parts of social work together to see what we can do and to do things differently in Scotland. So it's about having some national oversight. So that means an overview. It's not about making all social workers accountable to the National Social Work Agency, but it's having that national view about what's going on across the profession, about the areas that we need to improve in terms of education and workforce planning and training and development for all. And it's about creating a shared ambition. And I'll say a bit more about that in a minute. And it's also about creating a practice framework for social workers. So a bit like Agenda for Change in Health, but for social workers across Scotland, for student social workers to make their situation better, but from newly qualified social workers through to advanced practitioners such as yourselves. And it's about developing practice standards and supporting training and development of leaders in the future. So where we are just now is we're still in discussion with COSLA and Social Work Scotland and others around the creation of the National Social Work Agency, and it will be part of the proposals around the National Care Service from the Scottish Government. So this is not a done deal, colleagues. This is a discussion that's going on, and we would hope to conclude it in the next few months, but we'll need to see what Parliament says when the legislation gets into Parliament tomorrow. Next slide, thanks. So what are we talking about? Fundamentally, what we want to try and do, listening to all the feedback from social workers, and thank you to those of you who've engaged. We've had hundreds of social workers who've come along to sessions organised by us, organised by Unison, organised by SASW, organised by Social Work Scotland, and told us what they think. But that's not the end of the story, because we want you to continue to tell us what you think. And we know that you're saying there's too much legislation, it's too complex, there's too many policies. You're asking us, we're so confused. And if you look particularly at the childcare workforce, there's been a lot of work done by a really important piece of research done by SASW, where they interviewed 1,400 practitioners, not only social workers, health workers too, and some teachers, and looked at what was happening in the childcare sector. It's the Strand 4 report in SASW research, shows a complete a picture of confusion, it has to be said. So we know that's what you're saying. We know that we don't have the workforce planning that we need, and that we don't have the support for the front line in terms of implementing a lot of this. So basically what we're trying to do is design an agency that has a foot in policy. So when government goes to make policy, there is representation, there is a voice there for social workers to say, yeah, if you want to do that piece of policy, then here's what it will take to translate that into reality. You will need to have X number of social workers, and they will need to be trained to X level, and they'll need to be funded in that way. So that we're looking at not only what translating the policy, but also thinking about the workforce to deliver that policy and how we create that workforce. And this is all in partnership with COSLA and Social Work Scotland and SASW. And then looking at how we support implementation. And the support to implementation is really important. It's not just saying, look, there's a nice new piece of legislation, or there's a new policy, GURFI, for example, getting it right for everyone. Get on with it, and you lot get on with it and implement it. And if it's not implemented, well, it's obviously your fault and it's nobody else's fault. This is a partnership, colleagues. And we are looking to involve in this all of adult social work, including mental health and learning disability social work, justice social work, and children's social work. Next slide, thanks. So thinking about some of the things we are doing just now in preparation for what we hope to, we will agree with COSLA, a National Social Work Agency. There has been work ongoing. In this piece of work, I just wanted to showcase 3 pieces of work that are ongoing to give you an idea of the things we should be doing and we could be doing. This piece of work is about creating a vision for social work in Scotland. And you'll see there from the, it recognises the way in which social workers are all often pulled from pillar to post and the real challenges that we have. And this piece of work been led by SASW and Frank, who seems to have a finger in many pies in this discussion, has been particularly helpful in terms of driving this forward, but also had a lot of input from our colleagues in Unison and Social Work Scotland and other colleagues in SSC and IRIS and NES. So I'm labouring this because it's a work in progress, colleagues, and there is in fact a social work policy panel on the 5th of March. So social work policy panel is an open policy panel where any social worker can come along, it's online, and tell us what you think. So we will be circulating the details of that, but the 5th of March, I think it's a lunchtime session in a bid to get people along to tell us what you think. Because this is not about us in Scottish Government sitting on high and designing some vision for social work. This is a proper partnership approach, and that needs social workers themselves to be involved in that partnership. Next slide, thanks. We've also been consulting on an advanced practice framework for social work. So I mentioned it earlier. And last year we had, thank you very much if you came along, we had a couple, 200 or 300 social workers came along to various regional forums to talk about what they would like to see in the advanced practice framework for social work. And we've taken all your feedback, and IRIS are going to develop an outline advanced practice framework, which we'll be consulting on later in the year, I think round about autumn. Thank you. Somebody's put the social work policy panel sign up, but please do sign up. So this is about taking social workers from newly qualified social workers, thinking about what support level do our newly qualified social work staff need? How do we stop them leaving within 6 years? How do we make sure that they feel supported? And what needs to be in place to support them right through to you guys who are kind of like at the apex of this, to the mental health officers. And it's about what needs to be in place. So what do we need? How many people do we need? More people to support students. We need more people to support newly qualified social workers. How does that fit in an advanced practice framework? And we need it to be much more organised around the way in which we bring people into the pipeline for mental health officer training as well, and get them through into that level of practice. And I know you're all going to say, does it also involve remuneration? Yes, the question of remuneration is absolutely in there and in that discussion. But as you know, COSLA are representing your employers, so it's very much an employer's question, but it's one that we are actively discussing. So thinking about not just mental health officers, but also advanced practitioners in childcare, particularly those who have done the SCIM training and can interview children in a way that alongside police colleagues to ensure that they don't have to appear in court, for example, and risk management training for people the social workers who work in justice, basically. So there's right across the piece in terms of all social work, we're looking at advanced practice, and we're looking at a career framework alongside this, and how we put some of the learning and development resources in place that need to be in place to achieve this. So that's another work in progress. Next slide, thanks. And this is another work that's slightly further along in terms of the work that we've been doing. You'll know that since, well, most of you will probably know that since 2021, the government has been committed to a national trauma training transformation programme. And we looked at the trauma training transformation programme, and it's, by and large, a lot of this is run by NES, but we felt that there was a gap there in terms of what was required for social workers. And I think there was a lack of recognition of social workers as advanced practitioners in trauma, as people who deal with trauma day in, day out. In almost everything that social workers do, trauma is a factor. and very clearly, obviously, in mental health work. So next slide, thanks. One of the things we have done is we've set up a trauma team within Scottish Government, and this is what we would see, for example, in the implementation side of a national social work agency. So we've set up a trauma team. It's got social workers employed in it, social workers with mental health experience, social workers with justice experience, with childcare experience, with addiction experience, who themselves have all been trauma advanced practitioners in trauma. And we are offering trauma training across Scotland. Now, it's going to take us a while to roll this out across Scotland, but we did target newly qualified social workers and got a fantastic response last year. Almost all the newly qualified social workers in Scotland turned up for the training, which is great. But I think it also demonstrates a bit of what is lacking in their degree training as well. So we're talking to the universities about how do we build in some of the trauma training into the university courses as well. And we're developing a programme of implementation and support. So what we're doing is working with areas to look at the whole system and how does the whole system support this way of working? How does the whole system recognise the impact of trauma on people and how you actually work with people who are traumatised? So you can see there the 4 early adopters that have been, who have volunteered and been agreed to be part of the trauma training rollout, and we will learn a lot from that. And you'll see there that Glasgow have put forward their adult mental health services, which is great, and that's a multidisciplinary service. So I think about 40–45% of the staff in there are social workers, and the rest are staff from health and third sector. So that'll be really interesting to see how that goes. But that's a kind of example of the things that we hope to do more of if we are successful in managing to agree a national social work agency. And that's it, colleagues. It's a quick canter through from where we are just now, where we hope to be, recognising the very, very real challenges that we all face across the whole of social work, but absolutely in mental health services and with our mental health officer workforce, and what we hope to do in the future as a partnership to improve the current situation in social work. Thank you.
Thanks, Iona. Again, I can see that it's prompted a lot of discussion in the chat, and as Vicky highlighted, we, alongside Pierce, are about to start a small-scale research project about the retention of recently qualified MHOs. So it'd be really great to see how that fits in with the discussions that are ongoing at the moment. We'll take questions at the end if you'd like to put those in the chat, or put your hand up during question sessions. Next up, we have Susie Redmond, Ewan Williamson and Vida Rastaboska from the Highland MHO services.
Good morning, everyone. Thank you very much for the opportunity and the invitation to speak and present the Highland Mental Health Officer Service, and I think we called it Reflections from the Far North. So thank you for that opportunity.
Sorry, Susie, you've just hit mute.
Right, well, first schoolgirl mistake. Apologies. I'll repeat what I've just said. Thank you very much for the opportunity to come today to speak and to present the Highland MHO service. I think that this slide shows how the next 20 minutes will be spent, and I'm one of a trio of 3. I have the job of doing the scene setting, and I'm going to do that in a somewhat couthy way. Next slide, please.
Sorry, Susie, you're having a mute problem again.
I apologise. I don't know what is happening here. I'm really sorry. Again, my name is Susie Redmond. I'm one half of the Principal Mental Health Officer Service in Highland Council, and I'm the first of the trio to speak today. my reflections will be from last century, and will focus mainly on the operational development of the service and the description of how we've got to where we are today. That said, I think I'm probably the couthy one in this trio, and have got the scene setting remit. So we can perhaps move on to the next slide, and I'll start the sort of Jackanory once upon a time stuff. So next slide, please. Next slide, please.
You see that okay? It's the Susie story one.
Right, no, could I have the next slide, please? That's
Yeah.
better, thank you. Right, so once upon a time, when I first started practicing last century under the 84 and 47 Acts, I feel now like the dinosaur in the team, but when I practiced then, I learned very quickly on day 2 what I have taken with me every day since as one of the most important features of the MHO role. And I've said there the dinosaur's gob, and that's to catch your attention, obviously. I think day 2 I ended up in Sheriff Court defending a Section 18 application, and was asked, the first question I was asked was, Mrs. Redmond, how long have you been practicing as a qualified MHO? And realising the rabbit hole I was about to be dragged down, I found my gob and defended my profession, highlighted the training, highlighted the legislation, highlighted the code of practice, etc. And that was very much a message and a lesson I've taken with me every day since, that the MHO is required to defend their profession, promote the uniqueness and the crucial role that it has, which has already been highlighted by Neil and Julie, who spoke earlier, and also our role of safeguarding the health, safety and welfare and the human rights of the patient. So that message I have taken with me since then. Other reflections from last century are the training was different. It was more enmeshed in that the practice assessors also had sight of and commented on the academic work. The line manager also wrote a report, as well as the practice assessor. So the delivery of the training was different then. And operationally, I've touched on a service structure which was very different, and in fact much looser than it is now. I've written there grace and favour. There was a couple of social workers in the local psychiatric hospital, but other than that, if a detention was required in the community last century, a secretary rang round people who held an MHO qualification, and it was a grace and favour till somebody went out. There was always somebody to go out. There was no disaster that I recall, but that gives you heckle pins to think of that as a system now. It very much reflected that the MHO role was a secondary role to the substantive post that people held then. If we can perhaps move on to the next slide, please. And I'm on a roll with my animals. As you can see, in Highland, we've now become the chrysalis, and that's meant to evidence what grew over the next 5 years at the beginning of this century. Clearly, the growing need was becoming very evident. There was the imminence of the then new legislation. That resulted in a structure being put in place in Highland, the appointment of the principal mental health officer, supported at that time by 2 exclusive full-time MHOs. And duty rotas became a feature. The award course changed again with a separation of the academic and the practice components. Next slide, please. So our chrysalis in Highlands now a butterfly. From 2005 to 2012, and we saw this period of time saw significant structural changes, development of a management team, the principal mental health officer supported by 2 managers. We got a dedicated admin post. We really thought we'd won a watch when we did that. The forensic specialism was recognised and staffed, And there were further changes to the award course, competencies and a structure to the pro forma for the practice assessor became the norm. Then next slide, please. 2012 hit with integration, and Highland Council went it alone with the lead agency model, unlike its 31 local authority counterparts. And this necessitated the creation of a specialist MHO service, scoped at requiring 21 whole-time equivalent posts. Matching and selection processes were undertaken, and those who elected not to or who were unsuccessful in obtaining a post in the MHO service transferred to the NHS, where adult social work is currently housed. It became a Highland-wide service, both centralised and dispersed, with some MHOs based in localities at that point in 2012. And it's subdivided into 3 specialisms, as you can see there, and each specialism headed up by a practice lead. So a very definite and clear structure now exists. A daytime rota, and whoop-de-doo, we were all delighted at the no out of hours rota, with that falling to emergency social work, so you weren't being held out your bed at 3 in the morning any longer. So that was what integration brought us. Next slide. It also came with it costs. The loss of the social work role being a very obvious one. Some people grieved that, some people applauded it, depending on their particular perspective. Not being co-located any longer led to less sharing and liaison being more difficult, and a feeling of fragmentation. Next slide, please. But there were benefits, and there continue to be benefits. There are no competing demands of the social work role for the MHO. There is a role clarity not previously there, and an absolute acknowledgement and a promotion within Highland Council of the uniqueness and the autonomy, the value, the contribution of the role, as again Julie and Neil have touched on earlier, at a local, regional and national level. Career structure and succession planning, Iona spoke about this as well. In Highland, we found a bit what we think is an answer to our recruitment and retention crisis. That's been aided by the capacity building funding that we've received, allowing us to recruit practice assessors to take on that role, and some degree of filling in for people that are undertaking the training. We've increased the size of our service. We're now sitting at 24. But the main thrust of this has been the trainee scheme and the partnership with RGU, which we feel has afforded a career structure, succession planning, and has been the answer to the recruitment and retention crisis in Highland. I won't speak any more about that, because that's what you and Vida are going to speak about, and I'm not going to steal their scone. You can see the last 2 bullet points there are focusing on encouraging the workforce and with the development on celebrating success and so on. We've managed that in Highland. Hey, we won the award last year, which has pride of place on the wall in our office. Secondly, and finally, what I have seen, and this is why I've headed the slide, the voice times 2, because I've got polite now, I'm talking about a voice, not a gob. I've seen that MHOs now, unlike when I was a baby MHO last century, are shaping and influencing policy and legislation about practice through national forums and through Scottish Government consultations. So I end where I started, about the MHO's voice, which I believe has grown and should continue to grow. I'll hand over to Ewan now.
Thanks, Susie. So where are we now? I guess it's worth me answering this both literally and figuratively for those who perhaps don't know the Highlands. If you've not experienced the North Coast 500 yet, and seen the fresh air and mountainside that we try and entice people into our area with. First of all, I want to say, just reflecting on the theme, though, of embracing the unknown, I think Susie's journey through the MHO service, firstly as a practice lead and now as our principal MHO laterally, without her embrace of the unknown, we probably wouldn't have a service that's in the position that we are in. And it is actually a positive picture, despite national concerns that we all share. So here's our Highland setup. This is just to give you the scope of the challenge geographically. It is an area, the third of the land area of Scotland. It's the 7th highest population of the 32 authorities in Scotland. It has the lowest population density at 8 people per square kilometre. It's 10 times larger than Luxembourg, 20% larger than Wales, and almost the size of Belgium. That's often including Argyll and Bute, which is where our health board area covers, just for those who perhaps didn't know that already. As a local authority area goes, you can miss that small yellow area in the map out and just focus on the rest of it, which is big enough. So just on to the next slide. This is a current up-to-date service structure for you. So we're into the where are we now on the more figurative sense. At the moment, we have myself and Susie as principal mental health officers on a part-time basis, sharing that because Susie is flexibly retiring at the moment. We have 2 admin assistants, and we have just recruited to an information research and quality assurance officer role. This job involves a heavy focus on data and analysis and will help us make sense of what's happening locally and hopefully identify some areas where improvements can be made, looking at that alongside the very helpful MHO Mental Welfare Commission statistics that come out each year. We can probably start to get a sense of what's happening locally in more detail. For example, one of the areas of focus we want to try and make sense of is what is happening with EDC and MHO consent. That's going to be hopefully the first area that we can kind of look into and learn more, gain more insight. Our service structure at the moment covers 3 specialist areas. Donna White is our practice lead covering the Civil Mental Health Act. Jonaline McCaskill is our practice lead for adults with incapacity and that area. And myself and Karen share the forensic practice lead role on a part-time basis. If you're coming to workshop C, we're doing a wee bit later on corridors in the community and practical challenges in doing so. Just to give a plug to the crux of our service, which is our 20 whole-time equivalent MHOs. And you'll see there are 2 trainee MHOs, which we are supporting through the qualification. They're on target to qualify in September. On to the next slide. Now, I don't wish this to be green and red. I should have changed the colours because it looks like it's about positives and negatives in terms of our MHO population age demographic, and it certainly is not intended to illustrate that. There are no clear benefits about age demographic, but it does go without saying the service has lost a lot of experienced MHOs since 2015, as you can see on the left graphic. The main concern, however, about looking at that left-hand pie chart was that more than half of the MHO staff group were entitled to retire at any time with no contingency plan in place. This was before Susie and I, as principal MHOs, there didn't appear to be a contingency for that potential occurrence. So the issue, coupled by a lack of clear employment pathways for experienced mental health and community care social workers, meant the service was in a potential recruitment crisis. You can see how the age demographic has changed. That does come with positives and negatives. We've lost experience, like I say, and there is a lot of, you could argue, inexperience in our staff group now. But at the very least, we don't have the concern of half the MHO population retiring all of a sudden, which could have very easily happened in 2015. Thankfully, it didn't. So I've touched on an issue there, just going on to the next slide that I will talk about in more detail. What did I mean by the kind of pathway for experienced social workers in mental health or community care social work in exercising and practicing as MHOs and just moving seamlessly into that role? Well, Susie reflected on the 2012 integration model that we moved towards with the entirety of how adult health and social care budget moving to the NHS. One of the undesirable drawbacks of that integration was that the pathway into MHO practice for that experienced group of social workers was interrupted to some extent because their employment was with the NHS And obviously, as MHOs were statutorily required to be employed by the council. So there was an interruption there. And, you know, what would be the benefits of an NHS social worker to the NHS if they were looking simply to move into an MHO job with the council? That's just a kind of understandable reality. So we developed our trainee MHO scheme in response to that, which has enabled the local authority to employ an adequate number of MHOs. That means they can simply apply for a job and come into our service before having the qualification, if interested. So it's a proactive response to that challenging circumstances. I guess the last 2 points on this slide illustrate that there is only so much that fresh air and mountain scenery can entice people to the Highlands. So we have to think proactively as to how we grow our own. How do we support individuals who are already here to move into our MHO service? Just onto slide, yeah, that's the one. This is how our recruitment works. Now, I have actually got permission from Robert Gordon University. We have developed a trainee MHO policy in collaboration with Robert Gordon University, who provides the local MHO training. And they have given me permission to share that policy. I think that is probably the most important takeaway from our presentation, is that we are quite happy to share this knowledge. It has really helped us out as a local authority to overcome a potential recruitment crisis. And I'm actually pleased to say, I don't wish to rub this in because I know the national situation, but we have an adequate number of MHOs employed in Highland now. Our interview process is 3-phase. We encourage anyone without an MHO qualification who might be applying for an MHO role to approach a manager to discuss that with them prior to approaching Robert Gordon University for a course interview. Once they have that managerial endorsement, they move on to the RGU course interview stage. And then from that, upon successful interview from Robert Gordon, which is an independent process, they can then be eligible for a Highland Council job interview as a trainee MHO. So it's a formalised and very flexible partnership agreement, and it is possible for course applications to be considered at any time. Reality of that being that the course runs in September, so if we employ someone as a trainee in February, they are supported by and mentored by a qualified MHO, and all their work is shadowed and signed off by a qualified MHO. And that remains the same throughout their study and their progress, much as we would all support student MHOs anyway. Now, just onto the final slide. I'm not actually going to talk about that in too much detail. This is a list of the pros and cons to our trainee MHO scheme that we've come up with. I have already reflected that the recruitment matter could be considered a bit overly complex and convoluted, but actually it's necessary for it to remain quite independent in its 3-phase function. You know, we don't have a kind of say in the RGU interview process, and I think that's right and proper in that has to be they are looking at the individual social worker's ability to undergo the academic process. We're then simply thereafter looking at their potential as a trainee MHO while employed by Highland Council. So I think that does explain away that potential con. That's why I've put a question mark there. It is resource intensive. Our existing workforce must support that individual student, but it does pay dividends in the long run. And the redeployment is a kind of reality check as well, in that not everyone is going to be successful in study. So therefore, redeployment alongside our HR department is there for that already experienced social worker. So, and I'll not talk about the pros though, I'll hand on to our most recently graduated MHO in her own right. She came through the trainee scheme last year with distinction. And over to Vida. Thank you.
Thanks, Ewan. I'm mindful of the time, so I will try not to speak for too long. Hello, everyone. My name is Vida, and I'm a mental health officer. I joined the Inverness MHO team in 2022 via mental health trainee scheme, which was a few months before starting MHO course with Robert Gordon's University. The trainee scheme has provided me with the dynamic and supportive environment that promoted collaboration and continuous learning. And today I can confidently say that because of this opportunity, I experienced my experience is very much transformative that this scheme offered. And because of that, I enriched my professional expertise, which also influenced my personal growth. One of the scheme's notable features that I found particularly helpful has been the experience gained through practical application, as well as observing my colleagues in action in a wide range of day-to-day MHO practices, being included in discussions and challenged by being asked to find answers in various sources rather than just being provided with those answers required. I particularly enjoyed looking into evidence-based practices and reading academic journals that allowed me to build a solid foundation in understanding diverse perspectives in the mental health field. Now, being a participant in a trainee scheme meant that I did not have to worry about finding time to do those things during my private time. And so the pressure to try and achieve work-life balance was not there. This has definitely helped me to maintain my own mental health. Working alongside my qualified MHO colleagues has allowed me to apply theoretical knowledge to real world situations while having their expertise, experiences, and knowledge as my backup. In talking to my course mates, I understand that for some of them, opportunities for practical experiences had been somewhat limited, whereas I had a range to choose from. Now, my journey has not been without challenges, and at times I felt overwhelmed with the volume of practical experiences and the academic demands. However, I feel I was able to reach a reasonable balance through accessible and readily available support in my work environment from my line manager, my practice assessor, and my colleagues. And just to conclude, I would like to say that the mental health officer trainee scheme has been a pivotal chapter in my professional journey. I feel that knowledge gained, coupled up with the practical experiences and my personal growth, has positioned me in a good place to practice as a confident and competent mental health officer. Thank you very much, and it's back to you, Susie.
Okay, thank you, Ewan and Vida. So that concludes the reflections from the far north. So back to our main agenda, I believe.
Thank you so much to Susie, Ewan and Vida. Loving the animals and the gob, Susie. I think all social workers and MHOs appreciate the gob. The reflections over the year have given us lots of food for thought, and also in how you've embraced that change in MHO practice. I can see there's a lot of questions in the chat for the question section. Now, last but by no means least, I'm pleased to welcome Ms Marie Todd, MSP, Minister for Social Care, Mental Wellbeing and Sport.
Thanks very much. It's very lovely to be with you today, and particularly lovely to see Susie on screen there, a colleague, much valued colleague from a previous life. So it's really lovely to be here today. First off, on behalf of the Scottish Government, I want to thank SASW for organising today's conference and for inviting me to speak with you all. I'm really lucky in my job that I get to meet with lots of health and care professionals like you, and it's a real privilege to hear about the valuable work that's being done across Scotland. So I'm really grateful to have this opportunity to recognise the vital role that you play in supporting the recovery of people who are experiencing some of the greatest challenges that life may bring. Your work makes it possible for many people and families to live independent and fulfilling lives wherever possible. And I know that every day you help people to maximise their potential and to thrive. And you do this with incredible humility and great dignity. So thank you very much. There's another aspect to your role which is less often recognised, and I'm talking about the work that you do in building effective relationships with people and their relatives and their carers. And as many of you here today will know well, we are witnessing increased demand for mental health support and services and a rise in people presenting with more complex mental health needs. These pressures have been further exacerbated by the impact of the cost of living crisis, both on the person who is seeking support, but also on the people whose job it is to support them. This is having an impact on your well-being and on the ability of services to attract and retain the necessary number of professionals, resulting in the kinds of issues reported by the chief social workers in their annual report. So I'm talking here about issues like high vacancies and attrition rates. Chief social workers, officers have told us how acute difficulties in recruiting and identifying workers to train as MHOs have led to increased pressure on existing staff to complete statutory work. And we now know recruitment issues can have a really unpredictable impact on services, like jeopardising training and that very precious transfer of skills from senior practitioners to new colleagues. Chief Social Work Officers' annual reports continue to reflect the many challenges faced by mental health officer teams across Scotland, but crucially too, they highlight the exemplary qualities of the workforce. Now, this year's reports also provide really inspiring examples of excellence and initiatives which reflect the strong commitment of mental health professionals and their leaders to go the extra mile to meet the needs of the population. This work is centred around the same values that we believe in Scottish Government. At a national level, our work also seeks to reflect those values, so we're supporting, and in some cases we're driving forward, a substantial number of interventions to address mental health issues. And today I want to mention the Mental Health and Wellbeing Strategy, the Mental Health and Wellbeing Workforce Action Plan, and the Dementia Strategy. The vision behind the Mental Health and Wellbeing Strategy takes a whole person-centred approach to mental health. And achieving that vision will rely on having the right workforce in place, which means having a workforce that's diverse, that's skilled, sustainable, and able to operate at safe levels. We collaborated closely with you and with other partners to develop the strategy delivery plan and the workforce action plan, which we published jointly with COSLA last November, and I'm very grateful to the people in this room who helped to develop these plans. The Workforce Action Plans align to the National Workforce Strategy for Health and Social Care, and it places training, well-being, job satisfaction, and the principles of fair work at its heart. The action plan looks at the whole workforce journey, including how we attract, train, employ, and crucially nurture our mental health and wellbeing workforce. But this isn't all we're doing. Our new dementia strategy seeks to improve the lives of more than 90,000 people who are living with dementia in Scotland, of whom an estimated 3,200 people are under 65. Scotland's new dementia strategy sets out a 10-year vision for change that shared by the Scottish Government and COSLA. Now, to deliver our objectives, we established the National Dementia Lived Experience Panel, the Strategy Delivery Group, which have formal governance and accountability role in overseeing the strategy's implementation. What's new in Scotland's new dementia strategy is the new governance role envisioned for the voices of lived experience, and that represents a major shift from previous strategies as we put the emphasis onto the unique personal journey through dementia and its phases. For those people living with dementia, especially those who haven't been diagnosed, a timely visit from an MHO could be a life-changing event. Our new dementia strategy outlines how we'll collaborate with all partners to do more to ensure that people living with dementia have access to a timely diagnosis and are offered post-diagnostic support for up to a year. MHOs will play a significant part in bringing this benefit to those who need it. We recognise this work will place new demands on you and will require a new set of skills from you. So this new strategy will ensure there's increased awareness of how to support people experiencing dementia through their journey. In other words, investing in the workforce is a priority in the new strategy. Now, Iona Colvin's spoken here earlier, and we absolutely agree. Your work is essential to our mental health and wellbeing system and is central to the design and delivery of person-centred, safe and high-quality mental health services across Scotland. Tomorrow in the Chamber, my colleagues will debate the first stage of the National Care Service Scotland Bill. It's a big day. The NCS could be our once-in-a-lifetime opportunity to improve social care. Derek Feely's vision and my hope is that after tomorrow we will be a step closer to making real change happen with and for people. A strong and well-supported MHO workforce is absolutely key to delivering our national vision and strategies like the NCS and the Promise. And you might know that as part of the NCS, we're working to establish a national social work agency to help us to secure future investment in the social work profession, including MHOs, as well as enabling adequate workforce planning and development. Now, under current proposals, the National Social Work Agency will lead on social work improvement, education and workforce planning and development, raising the status of social work profession. These are some of the reasons that I am looking ahead forward to its creation, because it will bring absolutely tangible benefits to all of you and to the sector. Now, crucially, we're doing this in partnership with SASW, COSLA, Social Work Scotland, to ensure that the National Social Work Agency supports your vital work. So please, please, please engage with us at any and every opportunity you have, because for it to be effective, the National Social Work Agency gives you the leadership and the professional voice that you deserve and need. Many of the challenges that you're experiencing in the front lines are a consequence of the fact that there is no single national body that is tasked with having oversight of your professional development, your education, and the improvement of the service. There's a lack of national infrastructure, data and workforce planning, and that makes it really difficult to plan for future workforce requirements that are based on expected demand. The agency will help to address these issues, and it will ensure that you're supported and rewarded with suitable career progression, training and development, so that you can fulfill your potential and continue to deliver high quality services. Now, we believe that by valuing the workforce, we're empowering you to deliver the best possible service for the people of Scotland. The National Social Work Agency will help us to achieve that, and it will help us succeed at bringing together the entire sector to achieve a service that's fit for the future. You're an essential part of our mental health workforce. We are immensely grateful for the role that you play every day in translating our policies into life-changing acts of kindness. We know that there is nothing that we could do or achieve without your unique skills, knowledge and dedication. So today, as much as anything, I came here to shine a well-deserved spotlight on your work and the difference that you make to people's lives, and simply to say thank you.
Thanks, Miss Todd. You highlighted the breadth of work that MHOs undertake, and it'll be interesting to see how we can work together to address the MHO capacity issues moving forward. I'd like to take the opportunity again to extend our thanks to all the speakers for their contributions today. And I'd now like to give you the opportunity to ask some questions to our speakers. I can see that there are a wide variety of questions from the chat and from email. We may not get through all of the questions, but we will email the questions to the presenters and circulate the answers afterwards. So what we'll do is we'll start with direct questions and do our best to get through as many as possible before moving on to the written questions. So I'll now open the floor if you'd like to raise your hand, ask any questions that you wish, and note if there's any particular speaker that you would like to answer those. I may not see all of the hands, so if anyone wants to go first, if I can't see anyone. Oh, a deluge. What I'll maybe do then is just start with one of the questions from the chat. And I'll just go to Neil first. And it was just a question that we had from the chat there, Neil, in relation to how can citizenship be exercised in secure conditions?
Thanks, Lindsay, and thank you for the question. I mean, my discussion on citizenship was really talking about how people with mental health problems can play an active role in society, and obviously that's more challenging in secure care. But I still think that citizenship principles can be applied. And I suppose I'd go back to the 5 R's that I talked about. So it's about trying to find meaningful roles for people in secure care to contribute to that particular setting, encouraging people in secure care to take on certain responsibilities and to contribute to the life of the secure care environment. But it's also about having people's rights, respected. So I think it's a combination of just finding ways in which people can contribute and be citizens within that environment, albeit it's a very restricted environment. But I still think the same principles can apply. So that would be my response. Thanks.
Thank you very much. Certainly something close to my heart, working in secure conditions. So thank you very much. Next, we have a question for Ms. Todd and Iona. It's just in relation to the increased demand and staffing crisis. Is there any national plan to provide guidance or expectations for how local authorities might manage unallocated work, especially in relation to, for example, AWI work?
I'm happy to answer that, Lindsay, unless the Minister wants to. I can't see her. I'll answer it. So I think...
Go ahead, Iona.
I think this is an area of a lot of attention, basically. So I'm really interested in, I've been looking at the chat, Lindsay, and I'm really interested in meeting with colleagues who have any ideas about how we can better manage the current demand and particularly the waiting lists. And so it's an area of high focus. We have invested some money in adult social work, which was intended, so we put 22 million into adult social work, which was intended to alleviate some of the pressures here, and it seems to me that it's probably not worked. So what I would like to do is I'd like to speak to the colleagues who've put things in the chat about what, if any areas have got better ways of managing and how we might learn from that. I'm really interested in the presentation from the colleagues in Highland there. and we would want to make contact with them to look at, because I think that's a really interesting model. And also, I'm wondering if that model, although it's you know, you're saying, I think Ewan it was that said, you know, it's fitted for the Highlands, but actually it might well apply quite well across the rest of the country, particularly if local authorities band together into sort of more regional type arrangements. So I think there's something really interesting in that as well. So we don't have all the answers, and also you're not our workforce, your causeless workforce, your local government workforce, but obviously we're working hand in hand with them to look at solutions. So there's a number of things we're looking at. I also saw some issues, some points there around admin support. So that's another area we would be looking to see if we can develop some small tests of change with teams, if teams are interested in helping out with that, to see if that helps with the capacity. So we're open to ideas, Lindsay, really interested in things that are working, and certainly we will follow up with colleagues in Highland, because they said that was okay, we could bother them about that. But if other colleagues have good suggestions, then please let us know. We're more than happy to follow up.
That's great, Iona, and I'm just actually wondering, I know we have the regular SASW policy panels, but maybe a dedicated MHO one might be something that's beneficial to gather all those options and have more of a kind of a discussion around that.
That would be a really good idea, Lindsay, and I think that would be really helpful, because it's been absolutely fascinating this morning to see what colleagues are putting in the chat, because we are discussing these issues day in, day out with COSLA and with Social Work Scotland and with SASW. But to actually get your views as practitioners and managers is really, really helpful. So yeah, that would be a great idea, Lindsay. Thank you.
That's great. I'm sure Sarah can work wonders and get that organised in the future. We've got a question for Julie as well, just regarding EDCs. As you'll have seen from the chat, that prompted a lot of discussion, Julie. But question from Casey, just saying that she's seen a lot of an increase, or are we seeing an increase or decrease in overall numbers of EDCs? And could the reduction in MHO consent be due to a lower number of EDCs overall? Like, are they being used in true emergencies where there's no time for an MHO?
Thank you. As you say, I think we can see from the chat that no, they're not being done in true emergencies. I think all the chat's very, very clear about it's multifactorial. That and I think fine, there's a point just there made about somebody talking about trainees, junior doctors. There's a real lack of understanding. So it's multifactorial. There's work going on in health and social care partnerships. We pick it up with all health and social care partnerships. As I said, there's lots of work going on in relation to training GPs, in relation to training junior doctors, in relation to looking at out of hours and the spread of MHOs that can cover out of hours. So no, I'd like to say the numbers are because of true emergencies, but I think we all know they're not.
Thank you. I know that there is a range in terms of what comes through. I've got a question for Vida in terms of actually just having completed the course. How did you manage your feelings of being overwhelmed, and what advice would you give to current or new trainees coming on the course?
I think the fact that I have that support that I needed readily available in my immediate work environment made a huge difference. My practice assessor was amazing and gave me so much support, you know, in terms of the advice and moral support to get me through the course, because the course itself is quite a heavy course, very demanding course. So I suppose advice for those who are going through the course just now or thinking about it would be utilize your environment, immediate environment, as much as you can. Hopefully that support will be available for you. If not, raise the need for the support, and hopefully you will be heard. Yeah, it's all about, for me, it was all about that immediate support in my environment.
That's great. Thanks, Vida. And sticking with the Highlands, Ewan, I'm going to put you on the spot. We've got a question there about how have you found having MHO practice specialisms? What benefits has it had in the area?
Yeah, that's a good question. It's worked for us. You know, I've reflected on the kind of uniqueness of the Highland setup and why the model does work for us as an individual. Because certainly I think there are ideas that can be taken and applied elsewhere, but the specialism area works very well for us. It's perhaps more exclusive in terms of the forensic mental health officer specialism, in that the legislation can be quite complicated and get complicated quite quickly. I have to say that our other specialisms, the Civil Mental Health Act and Adults with Incapacity specialisms, quite often the MHOs working for each service will do a bit of each area of practice, so there isn't a kind of loss of any one skill in that regard. But our forensic practice model works well. We do see cases of where there's adults with incapacity related needs, Mental Health Act civil detentions, and we also work specifically with our criminal mental health law. So I'm maybe preaching to the choir in terms of yourself, Lindsay, and responding to you, but just that does seem to work. People know where to find us for advice, support and guidance. And if there is an interest in doing forensic practice out with operating within the forensic team, that is something that can be supported as well by our practice leads. Hope that answers the question. So it's not too siloed, because I think there would be a potential risk of loss of skill there.
Yeah, and there are benefits from having that kind of being involved in the specialisms, as you say, like forensics more often, and you become more familiar with the orders and different things, but you don't want to lose the general generic practice. We've got a question here for Iona or Ms. Todd, just in relation to, is there a major political imperative to respond to the need for dementia identification, or they can see that there's a major political imperative to respond to the need for dementia identification, but what are we to stop doing to enable us to undertake these new assessments? So basically, I think as MHOs, how do we, what enables us and what barriers are there in terms of undertaking the new assessments?
So, I mean, I can certainly answer from a dementia perspective that there is a growing need to develop a workforce to respond to dementia. We have, as everybody knows, I mean, we've got an ageing demographic, we've got a lot of people living longer with more complex needs, and the life expectancy for someone with a diagnosis of dementia is significantly higher than it used to be. So there is a need to develop a workforce to respond to that. And I think we see that in our dementia in our dementia plan, that it is required. So I'm not expecting individual social workers to take on that workload and give up something from their current job list. I think it is something that we will need to, with a view to developing a workforce that can meet the needs of the population, we will need to include dementia in our calculations going forward. I guess that's what I'm trying to say. There are I mean, I guess one of the imperatives for early identification is that there are on the horizon, and it's a very hopeful thing, potential treatments there. And, you know, we need to be, in the past, we haven't been great at identifying people with dementia at an early stage because there wasn't a treatment option, whilst, of course, support at an early stage was a really helpful intervention. But there is an imperative to identify people earlier because there are new treatments coming over the horizon, and that will have an impact. And you hear some of that debate playing out publicly, in that it's not as simple as providing a pathway for the drug to be available. There is lots of support that is required around an individual who gets a diagnosis like dementia, and undoubtedly social workers are part of that broader package of care and support.
Thank you. David, I saw you had your hand up. I don't know if
Yes, I mean,
paraphrased there.
There seemed to be an implication in what you said in your presentation that the mental health officers might have a role to play in this dementia emergency. I was concerned that if that didn't come with significant resource, that you were, hoping that Christmas will come soon.
No, I mean, I guess early conversations around incapacity and power of attorney and all these things. I mean, I'll let Iona come in, but early conversations for people with a diagnosis like that before they lose capacity could have a profound impact on how easy it is for them to navigate the system. But I agree, it does require to be funded and resourced. Iona?
Yeah, I think we're just at the stage. So I chaired the dementia strategy group and the development of the implementation plan, and we're just at the stage of looking at what workforce we need going forward, because this isn't just about MHOs. MHOs will be involved at some stages, but obviously adult social workers working in a more generic way are more likely to be involved significantly. So I think we need to, and occupational therapists are the other people who will be involved. So we need to think about the strategy. There's been a real tension in the strategy about where you invest the money. The strategy is very clearly being invested in communities, and very much, as the Minister has said, about particularly if we can get in early with people, then, and particularly given the developing field of drug treatment, then it means that people will be able to live better, longer and more safely in the communities. So it's really important that we now think about what the workforce is to support that, and there is a commitment within the dementia strategy to look at the workforce. And it's not just about MHOs, but MHOs obviously are clearly very important when people do lose their capacity, but other social workers will also be involved. So we will be looking at it. Thank you, David.
Thank you. Obviously, we've found out I'm not very good at reading questions and then saying what they are. So just as we're coming to the end of that, I think there's an interesting point there when we talk about the MHO capacity issues and what's happening on the ground, is also to speak to MHOs about what's made them make that decision to move from their posts and potentially move into other positions or look at agency work. So I think that would be something that would be beneficial to explore within that policy panel discussion about where we are moving forwards. But I think there's so many questions that we still have unanswered. I think it would be good to do those via email and circulate those with the slides when they come out. So just a big thank you again for the stimulating discussions. It's been really interesting to hear all the different developments and to look at kind of the questions that are coming up in the chat. I'd now like to welcome my co-vice, Zoe Sharp, just to tell us a little bit more about the National MHO Forum. If you've got any questions, Harry, if you could put them in the chat and we'll circulate it with the rest of the answers and the slides.
Thank you, Lindsay, for your kind introduction. As Lindsay advised, my name's Zoe Sharp and I'm Joint Vice Chair for the SASW National MHO Forum. I hope you've all been enjoying the conference so far. I've certainly found some inspiring discussions and reflections already, certainly sparked a few ideas from my own practice developments as a mental health officer. So I'm here on behalf of the Chair of the SASW National MHO Forum, Jo Savage. She's unfortunately unable to attend and she sends her apologies. Therefore, I'll provide you with a short recap of the work that's been undertaken by the SASW National MHO Forum over the last year on her behalf. I'm also very conscious I appear to have drawn the short straw. I've been given the slot just before lunchtime, therefore I aim to keep this as brief as possible, as I'm sure you're all keen to get a wee cuppa, a break, and to start digest some of the thoughts and inspirations from this morning's speakers. So the remit of the National MHO Forum, it centres on providing that collective environment for mental health officers across the 32 local authorities in Scotland. In order to achieve this, we meet as a group to promote good practice and also share practice concerns that we encounter as MHOs, as been raised in other presentations this morning. The National MHO Forum is open to both BASWA and non-BASWA members, with SASW acting as the secretariat. The forum itself is committed to developing and promoting a strong, independent voice for mental health officers in Scotland. As you'll be aware, the forum is made up of delegates from each local authority area across Scotland, and we're fortunately able to confirm that there are representatives from all the 32 local authority areas, which really enables a truly unique and valuable opportunity to approach and discuss MHO issues from a national perspective and the scope and reach of the forum itself. We also invite external members to provide updates on their work, including the Mental Welfare Commission and the Scottish Government, to name but a few. So within the last year, the MHO Forum has been chaired by Jo, with myself and Lindsay as joint vice chair. Our tenure within this role lasts the year, so March to March inclusive, and we're keen to identify and support other MHOs to consider taking up the reins, so to speak, and being part of the development and future of the forum. This is a unique and highly valuable role, which enables a fantastic opportunity to consider MHO practice from a different perspective and engage with MHOs on a national scale. At times as practitioners, we can often feel caught up in our day-to-day practice, often feel that we operate in those silos that we've referred to, not getting that opportunity to look beyond our own local authority area. The forum itself can afford an opportunity to look to see not only what's happening across Scotland, but to engage with it from a different angle. So the forum has the ability to engage on a policy level with all the national consultations that are being developed from the Scottish Government and provide a clear voice for MHOs within such consultations. An example of this has been discussion and engagement with the consultation on the Human Rights Bill when we met last July. And we're also involved within the review of MHO national standards, which remains ongoing and a topic for conversation within the forum. This last year has seen a few changes to the forum, and the basis around this has been about ensuring that the forum itself is for MHOs, by MHOs. And with this ethos in mind, the forum took a couple of notable changes which would help drive this vision forward. The first being the creation of a link worker setup. So the link worker setup enabled the delegates from each local authority area to have a dedicated and identified link worker who would be their direct contact to approach. This link worker role was facilitated between the chair, myself and Lindsay, and we aim to create a more direct contact with the forum to really aid in that engagement. And we also hope to create a closer dialogue between the delegates and the working of the forum as well, to ensure that we are truly representing and meeting the needs of our delegates. The second focus was hearing about MHO practice and service developments within local areas. And from encouraging this outlook, we've heard from some great developments across Scotland, including a supported decision-making pilot that is ongoing in South Ayrshire, and also the MHO trainee model adopted in Highland, which you have heard about already. And already, as you can see, it's generated and sparked quite a lot of discussion and has been very thought-provoking. But by bringing such developments to the forum, it has generated good discussions and reflections on what we can do in other areas. The forum itself has also changed. We've reduced the numbers of forums we hold per year. There are now only 3 meetings annually, and of course, this conference itself. The change in frequency reflects the understanding that MHOs are facing increased workload pressures and demands within their everyday practice that impedes their ability to always attend such events consistently. The forum also consists of the conference planning subgroup, and this group is made up of the chair, vice chair and nominated delegates, and it looks to ensure that the development and design of the annual conference is able to meet the current needs of MHOs in practice, which we're hoping we've achieved today. And if we haven't, please do not feel free to not hold back on any suggestions on your feedback and evaluation forms at the end. This feedback is truly invaluable to us. It enables us to develop a programme that is interesting, current and topical to you as an MHO. In terms of future developments for the National MHO Forum, it's with great pleasure that I'm able to announce that the next chair of the forum has been identified as Ewan Williamson. So some of you may already know Ewan from MHO practice. However, we have already been fortunate to have him and his colleagues Susie and Vida provide input already to the conference with their perspective on MHO practice from Highland. And as Ewan advised, him and his colleague Karen are also delivering to one of the workshops this afternoon. So hopefully you'll get a chance to meet him during the conference if you haven't already done so. I can also confirm that I'll be continuing with my role as Vice Chair and would like to show my ongoing commitment to the role and the development of the forum. However, it is crucial we do consider the longevity of the forum and also succession. So I would encourage anyone listening today interested in a Vice Chair or Chair role within the forum to get in touch with either myself, Ewan, Joe or Lindsay to express an interest. We'd be happy to discuss these roles further to see what part you can play in shaping the future of the National MHO Forum. I believe Sarah should have put our BASWA emails in the chat, so please feel free to reach out and contact us. So without further ado, I hope I've kept that as brief and concise as possible. And for most people who know me, that is often quite a challenge. If you could say it in 5 words, I'll undoubtedly use 10. So I will hand you back to Lindsay for the morning close and hope you've all enjoyed your lunch and are refreshed and revitalised for this afternoon's workshops. Thank you.
Thanks, Zoe. And that, as you say, brings us to the end of this morning. As mentioned earlier, there are workshops this afternoon. Please join the first workshop of your choosing at 1:15 sharp. And when this is finished, there'll be a 10-minute comfort break and you can join your second workshop at 2:25. The details of all 6 workshops and the relevant links are in page 3 of your programme. And you'll also have been sent a link to your workshops prior to the conference. But you can also see the links to these in the chat as well. If you've got any issues connecting, please email scotland@baswa.co.uk or write any queries you have in the chat just now. We'll then come back together on this link for the final keynote session at 3:30 with Tommy Whitelaw, and that's definitely a session not to be missed. If you're not able to join us this afternoon, I'd just like to take this opportunity to highlight that the next MHO Community of Practice will be on the 9th of May, and we'll be having a session hosted by Foxgrove, which I'm sure we'll all find interesting. So again, thank you to all of our presenters and sponsors and to all of you attending for your contributions so far. For those of you that are interested in becoming a BASWA member, if you're not already, please direct any queries to the scotland@baswa.co.uk mailbox, or you can look online at baswa.co.uk. This is the end of the morning plenary session. I hope you found it as interesting and energising, but hopefully not as stressful as I have. And I look forward to welcome you all back at 3:30. So thank you again and enjoy your lunch.
Thanks, bye.
Bye.